Okay, it's 12:02, so we're going to go ahead and get started. I know people will continue to trickle in over the course of the next few minutes, but I want to make sure that we have time to get through all of our content today. So I just wanted to say welcome to the first of our two-part webinar series this fall, Hope in Action. Today we are talking about the impact of suicidality on individuals in our communities. I do want to go over a few housekeeping things before we kind of get into introductions and the content for today. The first thing I want to go over is the CEU certificate receival process, as well as kind of our post survey. So there are going to be multiple ways for you to complete the post presentation survey that will then give you your CEU certificate. It should just pop up in an additional browser as soon as this training ends for you. If it does not, we're going to leave the lobby of this training open until 2 p.m. That lobby that you can kind of like that landing page when you click on the Zoom event, and the link to the survey will be in there, and your CEU certificate will be acquired via taking that survey. We're also going to make sure that a link to the survey for your CEU certificate is in our thank you email that we will send to all participants after this, as well as Brittany Talley, our lovely help on the back end, our technical support today, is going to make sure to put the link to that in the chat at the end as well. So there's quite a few ways that you guys should have access to the survey to then be able to receive your CEU certificate. If by the end of the day, for some reason, none of that is working for you, please just go ahead and send me an email or reach out via our HubSpot on the Camber website. So there should be, hopefully we'll be able to get that done. I know we've had some technical issues with that in the past. I also wanted to go ahead and talk about who Laurel and I are credentially and who these CEUs kind of like count for. So I'm a licensed master social worker and Laurel is a licensed special clinical social worker. And so essentially our CEUs count for anyone who is allowed to have that type of continuing education. So I know that we have attendees from all different professions here, from all different backgrounds. And so what we ask is that you do your own research about what counts towards your own continuing education. And then if there is some sort of special certification or like approval process that this content needs to go through in the future to count as a CEU for your specific field, if you wouldn't mind submitting a HubSpot request for training on our website or putting that in the survey or somehow letting us know if I see that there's a trend in us needing to have some sort of other approval for the majority or for a good portion of our attendees, we'll be happy to do that in the future and make sure that that is taken care of for you so that you really get that full continuing education benefit. Additionally, I will send out these slides in an email by the end of this week. So those should be coming. If you don't have them by the end of the day Friday, you can reach out to me. So let me know if you do not receive those. And then Brittany is also going to be helping us monitor our chat box today. I see some people are popping in there. So please, any questions you have, concerns, if you guys just want to kind of engage in dialogue with one another, we're really lucky to have this many people attending these webinars. It's a really phenomenal professional opportunity for everyone to kind of get to network and collaborate. So I know it's hard to pay attention to the training and be doing that, but feel free to kind of, answer each other's questions or collaborate as a professional community in the chat as we're going through. If there are any questions for us as presenters, Brittany will let us know and make sure that we get your question answered to the best of our ability if we have the knowledge to do so. Other than that, this is recording, so please be aware that we are recording this webinar. So anything you ask or that is presented is being recorded. And then lastly, but definitely not leastly, there are going to be 6 polling questions that we launch throughout this training. We ask that you guys engage with us. An hour and a half can be a long time sometimes. This is kind of a heavy topic, which we're going to talk about in a second. And, it just helps when we're all engaged and when we're all kind of, being interactive. So again, welcome and thank you so much for attending our first of 2 parts, Hope and Action, Impact of Suicidality on Individuals in Our Community. I am Alex Beineman. I am the Director of Program and Staff Development for Camber Mental Health. And I have been in the behavioral health field for about 10 years and with Camber for 7. I am very passionate about staff development and making sure that the people who do this really hard work every single day have the skills that they need and understanding that they need of mental health, of the different behaviors, of the different resources out there to serve, those struggling in our communities to the best of our abilities. And I'm joined by Laurel, and I'll let Laurel introduce herself.
Everyone, I'm Laurel Phillips. As Alex mentioned, I'm a licensed specialist clinical social worker, and I am the clinical director at our Children's Mercy Camber Mental Health Campus. So that is our newest mental wellness facility for adults and youth that will be opening in December in Olathe, Kansas. So I have been a licensed social worker for over 10 years, and I have worked for Camber for 7 years. I previously was a therapist at our Kansas City hospital location and then transitioned to a clinical leadership role. I am really passionate about ensuring that we're providing high quality, culturally competent, and trauma informed care. And I'm really looking forward to sharing more information about suicide so that we can all work to decrease suicide rates in our communities.
Yeah, and Laurel touched on it, but this is kind of a big shift for us. For those of you that have attended our webinar series, maybe historically, we are talking about adults today for the first time on this platform because that is a new line of care that we're going to be providing. So that's super exciting. It's something we're really passionate about. We really want to just increase access, for any community member that is in need. And so Laurel's part of the team kind of leading the way on that new facility opening. And at the very end of the training, we're going to kind of go over some of the details about that facility and how to access it if you maybe have someone you're working with who is in need of that care. So let's get into what we are covering today. So our goals for today is that after attending this training, we want all of you to be able to understand the growing need for mental health support and services for you as youth and adults. We also want you to understand how you can act in reducing stigma and increasing awareness and support. We're going to talk about mental health literacy. We're going to talk about how we don't talk about this subject enough, or how this is such a difficult thing for individuals to discuss, and how that can really hinder people's ability to access care. And then lastly, we really want to help you guys feel confident in your ability to identify when an individual may be at risk or is potentially experiencing some suicidality or exhibiting warning signs of suicidality. And before we move forward, I just want to go ahead and say that the topic that we're discussing today is personal, and we're going to talk about the far-reaching impacts that suicide has on our communities and on the families in our communities. And we know that this topic can be difficult. And I want everyone in here to feel as though we're putting your health first, your well-being first. If at any point this becomes too heavy or too anxiety inducing or too frustrating or hard to listen to, because it is a topic that a lot of people hold close to their hearts and have had personal experiences with, we encourage you to either leave the training or contact someone that is supportive of you or practice some extra self-care. It's important that we are able to talk about these things and learn about these things, but they're difficult all in the same, especially when they hit a little bit closer to home. So that is just kind of our extension of kind of just hoping that everyone is okay and wanting to put your well-being before the content that we're discussing today. So let's hop in with what is happening in the USA today. And some of the most recent, you're going to see some data across the course of this presentation that is anywhere from like 2018 to 2024. Different platforms are able to collect data at different rates. We get information typically at like a 2-year delay. So that's like, this is CDC data. And so you're seeing that at about a 2-year delay. So if you're ever confused about like, wait, what year was that, or that conflicts with this piece of data, just feel free to ask for some clarity and we'll clarify that. But it is kind of difficult to get all of that to be from the same year just because so many different organizations are gathering that data. So as of 2022, per the CDC, there were over 49,000 people who died by suicide, ages 12 and up. So it does not include any youth under the age of 12. And that equates to about 1 death every 11 minutes. Furthermore, we're looking at about 13.2 million who seriously thought about suicide, 3.8 million who made a plan for suicide, and 1.6 million who attempted suicide. And for every suicide death, there were about 11 emergency department visits for self-harm. We're going to get into the differences of suicidal behavior and self-harm here towards the end of our training, but that is a huge strain of resources. If you really just think about how that overall impacts the community, this is something that is regularly happening in most hospitals, most ER departments, and most communities. And then additionally, the CDC in 2022 has broken down methods of suicide. And so we're seeing that 55% of the completed suicides in 2022 were completed by firearm, 25% by suffocation, 12% by poison, and about 8% other. And that 55% is very important to kind of look at when we talk about access to firearms and some of the ways that we can prevent future suicide. We know that about 90% of individuals who attempt suicide and survive do not end up dying by suicide. And so that statistic is definitely going to come into play when we're talking about means reduction here in a little bit. And before we move to our next slide, I am going to attempt to launch a poll. Hopefully it behaves with me here. So give me just 1 minute. Okay. So I am launching poll 1. You should be able to answer it. And the question is, between Kansas and Missouri, which state do you think has a lower prevalence of mental health and a higher rate of access to care? I'm going to give everybody just a few minutes till we see some of these numbers slow down. Laurel, are you able to see that poll on the screen?
I see it from like the back end where I can end the poll, but I don't, yeah.
Okay, not just quite sure if everyone's able to see that.
Yeah, I'm not sure.
We're still getting a lot of respondents, so I'm going to go ahead and let it keep going until it slows down just a little bit. Okay, looks like we are, oh, maybe not, feeding back up. Okay, I think we're going to end the poll here and see if we can see these results. Okay, so we have 58% of people reporting that Kansas is the state with the lower prevalence of mental health issues and a higher rate of access to care, and about 42% are reporting that they think it is Missouri. So we will continue to move forward and see what the answer is. So according to the CDC in 2022, the second leading cause of death for 10 to 14-year-olds is suicide. And then it is Kansas that is ranked with lower mental health prevalence and higher access to care. This data is coming from the Mental Health America, or from Mental Health America, which is the nation's leading nonprofit dedicated to the promotion of mental health, well-being, and illness prevention. And basically the way that their ranking system works is if you're ranked in the numbers 1 through 13 as a state, it means that you have a lower prevalence of mental health, of mental illness, and a higher rate of access to care for youth. And then on the flip side of that, if you're ranked between 39 and 51, it indicates that you have a higher prevalence of mental illness for youth and a lower access to care. And so what's interesting here is Kansas is ranked 16. That means that they're not quite in that top 13, but they're close. And then Missouri is ranked 41. So Missouri is falling in that lower group of states that have high prevalence of mental health with a lower access to care. In Kansas, we're seeing about 13.09% of youth seriously consider suicide, and about 66.7% report a major depressive episode. In Missouri, we're seeing about 14.43% of youth seriously consider suicide, and 53.3% report a major depressive episode. And what I think is interesting here is that, and I apologize for a couple of those typos. What I think is interesting here is that we're seeing a larger prevalence of major depressive episodes reported in the state of Kansas, but we're seeing a lower suicide rate or youth that are seriously considering suicide. And I don't have all of the facts in front of me, but I feel like it's safe to infer that that probably is due to the access of care. And so that when kids are having these major depressive episodes, they're able to access care quicker. It's more available to them. Ideally, they're able to access that care by a provider that they feel comfortable with. And then we're seeing a little bit of the opposite of that in the state of Missouri. Other things that we can kind of note for specifically our youth in America today are that we know that those who identify as lesbian, gay, bisexual, or transgender often have a higher prevalence of suicidal thoughts to peers who are heterosexual. And we're going to talk a little bit more about those details in a minute, but we know that from years of research that that population does tend to be at higher risk. So we are going to do another poll here. Give me one moment and I will get it launched. Okay, so we know that certain occupations for adults can be associated with increased rates of suicide. Select which occupation you think has that association. It's fun to watch you guys respond and watch all the numbers.
Yeah.
People are still answering. Give it a few more seconds. Okay, it looks like oh, maybe not. Okay, it looks like we're slowing down here, so I'm gonna go ahead and end this poll and share the results. It looks like 41% of people said individuals in sales, 16% of people said food service workers, 30% of people said construction workers, and 12% said retail workers. And I do want to clarify, we are going to share the answer in the next slide. It does not mean the individuals in these professions, if you selected a profession that isn't the answer, do not have struggles with suicidality. It's just not reported as one of the leading occupations in research.
All right, so let's talk a little bit about what's happening today, specifically for some certain populations in our adult population. So, research shows that some groups have higher suicide rates than others. Suicide rates vary by race and ethnicity, by occupation, as well as depending on possibly where you live. So, based on race and ethnicity, the groups with the highest rates of suicide are non-Hispanic American Indians and Alaska Native people, followed by non-Hispanic white people. Other Americans with higher than average risks of suicide are our veterans and people who live in rural areas. And the answer to our polling question, some of workers in certain industries and occupations like mining and construction have higher risks as well. So we'll discuss a little bit more about specifically how suicide impacts those groups and adults a little bit further into our presentation, but we will kind of look at some of the specifics on why we might see those trends.
Awesome. So before we kind of dive deep into the specific populations and the things and the trends that we're seeing in both youth and adults, I feel like it's really important that we take a minute to talk about community impact. And this quote is by Ken Norton, the director of the National Association of Mental Illness in New Hampshire. And he says, a suicide is like a pebble in a pond, the waves ripple outward. When someone dies by suicide, the people impacted most dramatically are those closest to the person who died: friends, family, coworkers, classmates. And as a result, those who interacted regularly with that human are typically well affected. But those are not the only people affected. We often then kind of see a second wave or that second ripple of people affected by those who are able to complete suicide and die by suicide. And we're talking about members of an individual's community, other kids at school, members of faith communities, teammates, coworkers, maybe who are a little more distant and aren't in that employee's every single day kind of conversations and interactions. And so this is something that really does ripple outward, that really does affect communities in a big way. And in a study conducted in 2016, it estimated that about 115 people are exposed to every single suicide that is completed, with 1 in 5 reporting that that experience had a devastating impact or created a major life disruption for them. So if death by suicide is estimated to be occurring once every 11 minutes, then we're looking at a potential of 115 lives being disrupted every 11 minutes. That's roughly 16,000 people a day affected and 3,200 reporting that major life impact or that devastating impact on their life. Dr. Sydney Zazuk, MD and professor of psychiatry, touched on working with bereaved families, and this is a topic we're going to go into much more depth in our second part to this webinar series. But he talked a lot about the attention to stigma and how that is a big thing that the bereaved families of those who have completed suicide deal with. He referred to literature that compared bereaved families of suicide to other bereaved groups, and we're seeing that families who are bereaved by suicide have a higher level of rejection, of shame, of stigma, of a need to conceal a loved one's cause of death or blaming. We're also seeing like an intense feeling of guilt or responsibility for that death, which can really complicate the grief process. We see much more rumination and anger, and that can lead to complicated grief and depression. And so the kind of example that's given that I think is a good one is when someone dies by cancer, we're not asking why. It's awful and it's tragic and it's impactful and it's grief and it's horrible. But we don't have to sit there and ask why this person left us, even if we don't like that or we struggle with that acceptance. The reason is there. And often what we see when families are bereaved by suicide is that question of why, or what could I have done, or the guilt that kind of comes with knowing someone who completed a suicide. So we know that suicide of a family member leaves a massive mark on survivors. We can see from research that sometimes the function or dysfunction of the family prior to the completed suicide does kind of infer how the family might deal with it post-death. But other things such as the developmental level of children in the family can affect that, as well as we're seeing that marital breakup is much more common in parents who are bereaved by suicide versus parents who are not. We know that the effective prevention of suicide requires an understanding of risk factors. So in these next few slides, we're going to go through that. And like I said, in the next webinar, we're going to dive deep into this. We're going to talk about what it's like to work with those families and how to work with those families successfully. And we're going to look at some of the specific youth populations that are affected by suicide here next, so that we can look at what families are most likely receiving those services and how to best serve them. So before we move forward, we're going to launch another polling question. I feel like I'm getting pretty good at this. Okay. Which population, and this is just to clarify, this is youth, do you think saw a 36.6% increase in suicide rates between 2018 and 2021? Our numbers are still flying here. Let people continue to answer. We have everyone until about 12:25-ish. Okay, looks like, oh, got a few more answers coming in here. Okay, I think we're going to go ahead and end this poll. Thank you for those who responded. So we have 79% of people saying LGBTQ youth. We have 14% saying Asian youth and 15% saying Black youth. So we will hand over the presentation to Laurel and she'll let us know.
Yeah, so let's look a little deeper at suicide risks for youth. So a 2024 national survey on LGBTQ plus youth mental health found that more than 1 in 10 of LGBTQ plus youth attempted suicide in the past year. 39% of those LGBTQ plus young people seriously considered attempting suicide, and 46% of transgender youth seriously considered suicide. We also can see from this survey that LGBTQ plus youth of color reported higher rates of suicide and suicidal thoughts than white peers. 53% of LGBTQ plus young people reported experiencing recent symptoms of depression. So about nearly 3 in 5 transgender and non-binary young people, and more than 2 in 5 cisgender young people. So in answer to our polling question, we have Black youth ages 10 to 24 saw that increase of 36.6 in suicide rates from 2018 to 2021. And that's according to the new Morbidity and Mortality Weekly Report from the CDC. Looking more closely at that 10 to 24 age group, suicide rates were highest for that American Indian and Alaska Native population in 2021, but the greatest increase was seen for those who are Black. Rates for Black young people rose to that 36.6%, followed by 16.7% for that Alaskan Native population, and 13.9% for multiracial youth, 10.6% for Asian youth, 8.2% for Hispanic youth, and white youth aged 10 to 24 saw a 3.9% decrease throughout this time period. So this data should inform how we approach prevention and treatment. We really need to ensure inclusive and culturally competent assessment and treatment planning in order to provide adequate prevention to youth as a whole. We can't ignore these populations or assume that these populations would be as successful in treatment with the same methods as others. So we really want to be thoughtful about how we're approaching these and using this data to inform our practice.
Absolutely. And I think that before we put this presentation together, I probably would have answered LGBTQIA youth.
Yes. Yeah. As most folks, I think, see that too in our trend and our poll. But yeah, the data really shows that impact and that increase. So
we do have another poll before we move on. Okay, so our poll here says, which adult age group do you think has the highest suicide rate? And this is based on some 2022 data. Give it about 30-ish more seconds here. I think we're starting to slow down with some answers. Oh, there's another little uptick. Thank you guys so much for participating. It's interesting. It's fun to kind of see everyone's guesses. Okay, I'm gonna go ahead and click end poll and share these results. So when asked the question, what adult age group do you think has the highest suicide rate? The responses were 21% of you believe that it is 75 and older. 47. Reading my numbers backwards. Percent of you believe that it is 25 to 34-year-olds, and 36% of you believe that it is 45 to 64-year-olds. So let's see what the answer is. Okay, so in 2022, the CDC reported that 46.8% of all of the completed suicides were completed by 35 to 64-year-olds. However, those aged 75 and older have the highest rates of suicide. But to kind of back that up, I want to talk about that 35 to 64-year-old age range just a little bit more. For men, we're seeing that the highest rates of suicide in that group are completed by American Indian Alaska Natives and then non-Hispanic white men. And then the same demographics apply for women in that age group. We're also seeing that, like I said, age 75 and older has the highest rates of suicide, or some of the highest rates, with men specifically 75 and older having the highest rate of suicide. That's going to be kind of an interesting fact. We're going to talk about veterans in a minute, and we'll talk about why that's kind of contradictory information and kind of interesting. In addition, we have the LGBTQIA plus population, and I am going to read some statistics here because they're really interesting and I want to make sure I get them correct. So if I'm looking down, that's why. But there was a study conducted in 2021, and this is specifically for LGBTQ. So we're not talking about transgender adults in this specific study. But it was completed in 2021 and published in the American Journal of Preventive Medicine. And the goal of this study was to really understand how suicide risk among lesbian, gay, and bisexual adults is not uniform. It's not easy to kind of infer that that's just why someone is at risk of suicide, but it varies significantly based on the intersection of sexual identity with gender, with age, and with race and ethnicity. And so we know that the overall suicide attempts or struggles with suicidal thoughts is increased. So the suicide risk is 3 to 6 times higher for lesbian, gay, and bisexual adults than heterosexual adults across all adult ages, race, and ethnicity groups. If we look at it by gender, among gay and bisexual men, 12 to 17% report suicidal thoughts, 7% are making plans, and 3% are attempting. If we're looking at lesbian and bisexual women, we're seeing that 11 to 20% have suicidal thoughts. So we're seeing an increase in the thoughts about suicide in women. We're seeing 7% of them make plans, and again, 3% of them attempting suicide. So we're seeing kind of those higher levels across with LGBT individuals. However, it does differentiate a little bit between men and women. When we start to factor race and ethnicity and gender in kind of into the equation and look at that intersection, we see that lesbian or bisexual women that are also Black women had lower risks of suicidal thoughts and plans compared to white women. And that bisexual women, both Black and white, reported higher rates of suicidal thoughts compared to just lesbian or gay women. So we're looking at that bisexual community, especially the female bisexual community being a little bit more impacted by suicide and having a little bit of an increased struggle. When we look at age, the suicide risk was particularly higher among bisexual women aged 35 to 64 compared to lesbian or gay women of that same age group. And I know that as a member of the LGBTQ community myself, you see a lot of information being shared right now about the inclusivity of bi individuals and making sure that is a portion of that population that is seen and advocated for and understood. And I think that these statistics really show the need for that need for inclusion and acceptance for the whole community, but in particular for the bisexual part of that community. Now, because that study didn't include transgender adults, I do have some additional information that was gleaned from a study in the Williams Institute at UCLA. And what they are finding is that 81% of transgender adults in the US have considered suicide at one point or another. It's a really big number. And then we have 42% attempting. And then in addition to that, 56% have engaged in non-suicidal self-injury over their lifetime. So that is a population that is significantly affected by adversity and discrimination and mental health. And we're seeing that in their rates of struggling with suicide regularly. So that's definitely something to pay attention to, something to advocate for, and something to make sure that if you are working with individuals in that community, you are kind of aware of the risk and compensating for how we can provide some additional care, to Laurel's point, some culturally competent care, and really making sure what we're doing is working for them. Additionally, we can talk about veterans. We know that veterans struggle with mental health. That's more of like a commonly well-known fact. But if you look at the data from the 2023 National Veteran Suicide Prevention Annual Report, now their data is a little bit more delayed. So we're looking at 2021 data when we're looking at this report. Per the report, 15.9% of 2021 suicides were veterans. So out of all the suicides completed in 2021, almost 16% of them were veterans. And then from 2020 to 2021, all veteran age groups, suicide rates rose between 7.1% and 10.7%, depending on the age group, except for veterans 75 years and older. That age group actually decreased by 8%, which is really interesting when we see that the population in general, like the US population in general, we see the highest amount of suicide occurring with men over 75. However, when we're looking at just the veteran community, that's actually one of the more protected communities. They are seeing that pretty significant decrease of 8%. And then the last thing that I'll note from this annual report is that from 2010 to 2020, so over the course of that decade, the suicide rate among those who completed suicide within 12 months of separating from active duty went from 34.8% to 47.6%. So this really just highlights the need for us to improve services to target those who are exiting active duty and make sure that we have the resources in place to be available to them immediately to ensure that that transition is something that they have support in, to be there to listen and to understand and to have the resources they need accessible so that they can be as successful as possible when they do separate from active duty. We know that suicide and suicidal behavior is influenced by negative cognitions, and those negative cognitions are developed by the way we play and live and work and learn and engage in our communities. And so we're going to kind of get into some of the key vulnerabilities and contributing factors that are not necessarily just population, but some of what's going on in our environment around us and what people are experiencing that put both youth and adults at a potentially higher risk for suicide.
Alex, just before we move on, there was a question.
Oh, yeah.
Someone was asking, I know you had lots of good information on that, cross-sector rates for adults that are LGBTQ and then race and some of those other pieces. Someone was asking if there's information on that for youth. I don't have any in-depth specific rates, but we do know that based on that survey completed in 2024 by the Trevor Project, that youth of color who are also LGBTQ plus did experience higher rates of seriously considering attempting suicide in the past. So definitely that's something we can dig more into. And if you're interested in looking into that information, again, that resource is the 2024 National Survey on LGBTQ plus youth mental health. And that was completed by the trevorproject.org. So someone
if you're
wanted
not familiar with the Trevor Project, the Trevor Project is a phenomenal resource. It's everything from data collection to crisis resources to information. And it's something that is gleaned like towards LGBTQI youth. So it's not just for the adults working with them. It's really interactive and engaging. And so if you've never checked that out, I highly encourage you to. It is a wonderful, wonderful, wonderful organization and information platform.
Okay, so let's talk a little bit about key vulnerabilities and contributing factors for adults. So we kind of group this into a few different categories. So we have economic health and public assistance, substance access and misuse, and then means and access to firearms. So suicide and suicidal behavior are influenced by those negative conditions that Alex was just mentioning. Those conditions are sometimes called social determinants of health. That can include racism, discrimination in society, economic hardship, limited affordable housing, lack of educational opportunities, barriers to physical and mental health, among others. Some of the additional factors that can increase suicide risks include relationship problems or feeling a lack of connectedness to others, easy access to those lethal means, and experiences of violence like childhood abuse, neglect, adverse childhood experiences, and serious health conditions. So while anyone can experience suicide risks, some populations experience more of these social determinants of health than the general US population. So that excess burden of suicide in some populations is what can be called a health disparity. So examples of groups experiencing these suicide health disparities include veterans, people who live in rural areas, sexual and gender minorities, middle-aged adults, people of color, and tribal populations. So those are some of those groups we've already recognized at a higher risk. So research supports multiple contributing factors for adults. Like I mentioned, that availability to means, such as alcohol, drugs, and firearms, spending on social programs like SNAP, and even minimum wage. So according to a 2019 study by Gettner et al., they reviewed data from all 50 states between 2006 and 2016, and they were assessing for exact times when there were specific changes to minimum wage in each state. And they found that for every $1 of inflation-adjusted increase, there was an associated 1.9% drop in suicide rates for that state. That amounts to about a decrease of 8,000 suicides over that time period. So that's a huge impact. Flavin and Radcliffe found in 2009 that if every state increased public assistance by $45 annually, it would translate into 3,000 fewer suicides per year. Alcohol availability shows an increased risk of suicide by 1.65 times for males and 1.4 times for females. And as we mentioned, that access to firearms and lethal means can really impact survival rates overall. So passage of firearm restriction laws can reduce firearm suicide and perhaps overall suicide rates in a state. It's really important to, again, touch on what we saw earlier from the CDC, which is that firearms are the most common method used in suicide, and firearms were used in more than 50% of suicides in 2022. So addressing these negative conditions and factors can help prevent suicide and lethal suicide attempts.
It's so interesting to just look at some of that, Laurel, and see how some of these seem like pretty, I mean, and I know on the grand scheme, they're not as minor as it feels, but just looking at that like $1 and the impact that that can have, I mean, 1.9% is a lot of people alive, and things like that. And so it's just really interesting to conceptualize it that way and understand that we're not asking for, I mean, major world changes would be great, but we're not asking, for everything in the world to be turned upside down. These small adjustments that people can come together and can make really, really, really impactful improvements in the suicide rates and the community's health, et cetera.
Yeah, definitely. Very actionable, yes, concrete things.
Yeah. Which I feel like sometimes we get so overwhelmed because it feels like we need these like massive fixes and overhaul of all these systems. And while there are areas that do need that, I think when you see it broken down like that, that feels a lot more digestible and a lot more doable than, redoing everything.
Exactly. Yes, definitely. Okay, so let's talk a little bit about those key vulnerabilities and contributing factors for our youth. So we kind of categorize these into three groups here too: developmental vulnerabilities, social media influence, and suicide clusters. So our youth are impacted by those same societal and environmental factors as adults. However, it's also compounded by that developmental factor as well. So according to an article by Johan Bilson, when people think about suicide, they are ambivalent about that decision. It's often an impulsive decision when that ambivalence changes from thinking to action. So that impulsive shift is often a reaction to some sort of acute psychosocial stressor. So this tells us two things about youth being particularly vulnerable. Because of the stage of brain development that our youth are in, they are more likely to act impulsively as thoughts come across their brain. And they're also more likely to have deep emotional reactions to those psychosocial stressors. Especially our teenagers, that amygdala is just on fire for them, right? When they're developing through those teen years, and that amygdala is what kind of harbors all those really deep emotional reactions. Everything can really feel really intense to those youth. And so they're going to experience those deep emotional reactions and be more likely to be impulsive. So that just puts them at a greater risk. Although adults and youth are both impacted by social media, youth again are more vulnerable due to that stage of brain development they're in. So research has shown a correlation between increased social media use, worsening depression, and suicidality. Although social media can help us feel like we're more increased our social interactions, it really shouldn't replace those in-person social interactions overall. According to an article, the social media's influence on suicide in adolescence, overuse of social media sites results in limited interpersonal reactions, increased risks of cyberbullying, increased life comparison and dissatisfaction, and higher rates of exposure to suicide-related accounts. So as adults, we can often, not all the time, but often consume social media with a lens of understanding that it is a curated environment, right? It's everyone's best day of their life, every day, all day, but that's not real life either. And our youth are just more susceptible to feeling as though that when they consume that media and that content, that is what everyone else is experiencing all the time. It can make it really hard for them to separate what appears to be those best moments from the reality of someone having a bad day. Yeah. Research also shows that increased screen time before bed can really impact our sleep hygiene. And we know that sleep hygiene is an important factor contributing to our mental well-being as well. And that social media can distract us from our hobbies, our homework, and other responsibilities. I think we can all admit there has been a time where we meant to get up off the couch and do the laundry. And instead you find that you've spent an hour scrolling on TikTok or being on Facebook or Snap or whatever that social media is. It's really easy for us to get distracted from those things that also give us fulfillment and joy in life by just kind of getting sucked into social media.
Laurel, we have a question about
Oh
social media
yeah.
in the chat box. It says, did they identify what overuse of social media is or what safer levels would be?
Yeah, it did not identify anything specifically for overuse. I mean, I think there's some ratios out there that talk about, for every certain, hour of social media use or 30 minutes that you want to have, an hour or more of in-person contact. But no, I don't know that I saw specifically what overuse would be identified as in that
Yeah, I don't
article.
have info for the specific training, but I have
Yeah.
attended a training previously that was led by by a psychiatrist who was looking at brain development in relation to social media exposure. I know that I put in the chat that I'm going to put together an additional like supplemental documentation with some of the statistics we haven't included on the slide. So I'll try to include a link if I can find either a link to that presentation or some of that research, because I know that it does exist out there. It looks like we have another question, I think. Is the research showing that exposure to suicide related accounts leads to an increase in suicide? And I don't have specific information on that right now either.
Yeah.
Happy
I
to
don't
try to get it.
Yeah, I don't either. I mean, we'll talk a little bit about suicide clusters, which I think can kind of touch on probably a similar experience to if someone's exposed to those suicide accounts as well. So we can kind of get into suicide clusters. We'll see if that answers that question just a little bit. So suicide clusters are a group of suicides or suicide attempts that occur close together in time, space, or both. Sorry. Okay. In time, space, or both. There we go. Or both time and space. More than would normally be observed in a typical community experience. So, although suicide clusters are rare, a suicide might trigger others who are vulnerable to attempting suicide, especially when the death is really highly publicized. So, I think that's where you could potentially see that connection to those suicide accounts, because there's a greater likelihood for someone to have that exposure to other folks that are completing suicide. Even if contagion doesn't occur, clusters can also have a profound effect and create anxiety among community members. So Alex touched on this a little bit when she mentioned that ripple effect of how suicide can impact our community. So it can increase anxiety, which also is important to kind of support folks through to kind of decrease and contain a cluster. And then it can also increase that social stigma, those feelings of guilt, shame, anger, all of those things can increase among family and community members. And that's increasing risk for additional suicides as well.
I'm loving seeing I'm monitoring our chat while you're talking,
Yeah.
and there's just such like great conversation just about kind of how complex all of this is for youth and what are those limits. And someone made a really
Yes.
good point that a consideration when we're talking about social media is also that for more marginalized populations, specifically queer youth, that can be a way to connect. And so how do you kind of regulate that as a caregiver or a parent, or how do you know what the safe thing to do is? And then I think that that's compounded by whether or not that child is safe being out. Because as a parent, you might not know that that is, or you may unfortunately disapprove that that's something that your child is accessing via the internet. And so I think it's just so difficult
Yeah.
to understand. But I really think, and I know we're going to talk about kind of some of those protective and
Right.
proactive measures, but I really think a lot about it is starting to have these conversations, talking to not only parents and caregivers, but talking to youth about, hey, like this is something you engage in, do you understand that there are risks or that you could come across things that are unsafe, and let's make a plan to
Yeah.
handle that. I know that right before this training, Laurel and I and another coworker were discussing just kind of adolescent brain development and experiences like personally that people's kids were having, and just with the cyberbullying and the life comparison, just kind of that narcissistic phase of brain development where you don't really understand the impact that what you're doing or saying has on another individual. And then on the flip side, the individual who's unfortunately potentially at the receiving end of that bullying being impulsive really
Mhm.
just kind of creates a perfect storm for potential tragedy.
Yep. Definitely.
Okay, we have one more polling question. Actually, this is our second to last polling question, but our last question, I think I'll be mad if everybody doesn't get it right. You'll see why when we get there. So I'm going to go ahead and launch this question. Poll number 5. It's a simple true or false question, but if an individual is struggling with self-harm, they must be suicidal. And the answers are pouring in. And while those answers pour in, I'll just also share something else that was shared, that when you compound the internet and social media, we don't get a relief from that bullying, or kids don't.
Yeah.
So even if they're experiencing it at school, they're now experiencing it potentially around the clock, which just really compounds the issue and makes it really difficult to intervene. And then it's not easy to restrict a kid's access to technology. They're not
Yeah.
happy about it. It can be
Yeah.
difficult, etc. So we still have a few answers coming in here. I'll give it about 20 more seconds. I'll also say that I love everyone telling me where they're from in the chat
I
box.
know.
It's so
It's
exciting to
fun.
see this, let's say, such a large community, and just seeing that people are willing to tune in and have such a vital conversation from all over.
Yes. Yes.
Okay, so I'm going to go ahead and end this poll. And we have about 1% of people saying that they believe that true. If you are struggling with self-harm, you must have some suicidality that you're also struggling with. And about 99% of people are saying that that is false. So we will, again, let Laurel let us know. And I think I launched a slide too soon. So actually it's
Yeah,
on
we'll get to it. That's all right.
but we're going to get to that. I promise.
We'll get to the answer. We're going to talk a little bit first about mental health literacy. So we've reviewed a lot of current data on how suicide impacts our communities. We know that the earlier mental health problems are identified and treated, the better those long-term outcomes are. And the best way to identify mental health problems early is to ensure community members understand the early warning signs, ways to help, and how to access support. And that really is mental health literacy in action. So it's important that we're practicing mental health literacy in order to decrease stigma and increase likelihood of people seeking support. And although mental health literacy is not specific to suicide prevention, it is an important piece to that puzzle. So ensuring that the community has mental health literacy, we can increase support for the community, from the community, family, and friends, which is also already an identified protective factor for suicide prevention, according to the CDC. So here we have just 5 ways to reduce that stigma. So being informed, you guys are already doing that today by participating in this webinar with us, by making sure you have the most recent information, that you're talking about mental health and mental health issues. Having a conversation, so talking openly with others about mental health. I know, we talked a little bit just now about how exposure to suicide can increase someone potentially thinking about it, but that doesn't mean we don't want to talk about it either, right? There's a balance. We want folks to have the language. They're going to have thoughts and feelings about these things. And if they have the language to describe what they're experiencing, they'll be more likely to seek support and feel less isolated as well. We want to use person-first language. So making sure that we're not using a person's diagnosis as an adjective. We want to talk about people experiencing suicidal thoughts or people experiencing depression, and really put that person first to help decrease that stigma as well. We want to normalize treatment. So treating mental health care as a part of health care. If you had a broken leg, you would go to the ER. Hopefully you would go to the ER, you would get some sort of cast, and then you would follow up with outpatient care. We want that everyone to feel just as comfortable doing and seeking out crisis mental health services and ongoing outpatient care. And by doing that, we'll continue that ongoing care and making sure that folks have that preventative mental health care. And we also want to recognize self-stigma. So knowing that we're not alone and that there's ways to cope and overcome the stigma that anyone might be experiencing.
Absolutely. And we have an interesting kind of fact that was shared in the chat, so I want to share it.
Sure.
I'm sure everyone can see it, but I want to draw attention to it. It was shared that House Bill 2567 in Kansas has really impacted how school mental health workers with students with suicidal ideation are able to access care, because now they must attempt to get the parents' permission first before screening a student. And we know that time is really of the essence in these situations, and that with the stigma of the mental health and the political climate, and parents who maybe don't have the mental health knowledge, or who are kind of affected by that stigma or fear of judgment, are maybe not allowing some of their children to be screened, which is so dangerous. And I don't think any parent would do that out of malintention, just out of misinformation. And so that's just something that is currently really affecting the Kansas school population right now. And I really appreciate whoever shared this, because, those are things we need to be aware of. Laws change constantly for mental health professionals and around subjects like this, and keeping up with them is difficult, and it can be frustrating to constantly feel like you have to relearn that. So I just definitely appreciate that kind of note to that law, and also just, the attention to the importance of the mental health literacy and stigma reduction. Sure. Okay, so just a reminder that we all took that poll about true or false, whether or not self-harm indicates that someone is suicidal always.
Yeah.
And we're going to talk a little bit about that, because understanding this is part of mental health literacy.
Yeah. So in order to practice strong mental health literacy, we do want to kind of talk about that difference between self-harm and suicidality. So according to the Center for Suicide Prevention, the majority of those who self-injure do not have suicidal thoughts when self-injuring. That doesn't mean they don't have suicidal thoughts, right? This is specifically talking about when they're self-injuring, they do not have those suicidal thoughts. So although self-harm is not the same as suicide, self-harm can escalate into suicidal behaviors. The intent to die can change over time. And one study found that almost half of people who self-harm reported at least one suicide attempt as well. So self-harm can also lead to suicide when self-harm is no longer an effective coping method, or it ceases to offset those feelings caused by stress or trauma. And also in a crisis situation, individuals who self-harm can become somewhat desensitized and may view a suicide attempt as less frightening. People who self-harm, they self-harm for a number of reasons, including to feel better, to communicate their emotional pain, to feel a sense of control, and possibly to punish themselves. And because self-harm can become suicide, it is highly recommended that every patient who self-harms be assessed for suicide risk. So although they are not, right, like you can self-harm without feeling suicidal, it still puts someone at greater risk for suicide. And so we do still want to make sure that we're assessing folks that are actively self-harming or have a history of self-harm for suicide as well.
Thank you, Laura. I feel like that's such an important distinction, and one that gets muddy really quick and can be difficult to understand.
Yeah, definitely.
Okay. Let's see what's next. So we're going to get into talking about some of the risk factors for suicidal behavior here. And I'm sure that none of these are going to be, brand new information to anybody, but we're going to get into kind of understanding how these are conceptualized in today's world. And so the first kind of category we hear is that harmful or hurtful relational experiences. And bullying is at the top of that list, especially for youth. We've had quite an extensive conversation about bullying, but I think it's one of the biggest things that plagues our youth, and I think it's hard to respond to and it's hard to intervene on, because especially the cyberbullying, a lot of it is anonymous or it's happening and we're not aware of it. And so I feel like something that is super important here is to really make sure that we're having conversations about what bullying is, what bullying looks like, and who to talk to if you're experiencing that, and how to talk about it if you're experiencing that. We also know that a risk factor for suicidal behavior is a family's or loved one's history of suicide. So kind of knowing that, making sure that we're accessing care for individuals. We know that almost half of the suicides completed last year were just that population of, I'm going to misquote myself, but I think I said 34 to 65-year-olds, and that we're seeing our 75 and older population with the most. And so this is something that kids are experiencing, and that other loved ones are experiencing pretty regularly. And so making sure that when that risk factor is identified, we respond to it and we monitor it, and we make sure that the supports are in place. Violence and conflict in relationships. So looking at domestic violence, looking at, other types of psychological abuse or physical abuse, or just insane conflict. It's exhausting to be in conflict with people consistently, and if you're feeling stuck in that, that can lead to some pretty hopeless and helpless feelings. And then social isolation, and I think that Laurel's going to touch on it in a little bit, but I think the social isolation is especially hard when we're coming out of the pandemic. We were isolated. We have been very isolated. In a lot of ways, we're still isolated. We're working from home, which people love, but it also can be difficult to get the connection that you need or to build some of the relationships. I know that I, as a 31-year-old, have a lot of people who are like, oh my God, making friends as an adult is really hard, especially if you don't have, children, and then you're meeting their children, their friends, parents, and things like that. And so just really looking at, how can we bring communities together in response to that? Positives. I've heard of some really cool different things going on in communities to bring adults together, to kind of give that opportunity for people to meet and greet and get to know one another and try to build a better and more supportive social circle. Some of the personal factors, some of the personal factors for suicide risk, and they're not all listed here. I have some additional ones listed below, but having a previous attempt. And I saw that there was a question in the chat about what the likelihood of having a second attempt after a first attempt is. And I don't have that exact number. I know I've read that research before, but I don't know off the top of my head. Laurel, do you have a specific answer to that?
I don't have a specific number, but I can tell you that, the research shows that does put someone at higher risk. And we'll talk a little bit more towards the end of our presentation about the CSSRS assessment. And that is a question within that suicide risk assessment, is if you've had a previous episode or thoughts and attempts previously. So there is some research. I just don't have the specific numbers to give right now, but definitely it does put people at a higher risk.
Yeah. And I just wrote that down. I know I'm going to put together that additional info sheet. So I'll try to get some of those numbers and put it on there. I'm having a history of mental illness, of any mental illness, but especially of mental illnesses related to depression and some of those struggles, is definitely a personal risk factor. Substance misuse, which we see an increased risk of substance misuse in the LGBTQIA plus community, as well as in veterans and certain occupations. And so knowing that and understanding kind of the slip into substance misuse and how that puts someone at additional risk for suicide is really important. Financial problems. I don't know that there's any stress like financial stress out there. And so we're really, trying to ensure that we can identify when that's a major stressor in someone's life and help them. And then loss, just experiencing grief can definitely be a risk factor. Additional personal risk factors are like if someone has aggressive or impulsive tendencies. We talked a lot about the impulsiveness with youth, but those impulsive factors can carry over into adulthood. Having criminal or legal problems, especially if the person's crime is of certain categories that would maybe be viewed a certain way, or depending on sentencing and things like that. Having a current or prior history of adverse incidences. So if anyone is not familiar with the ACEs study, I highly suggest that you look into it. But an adverse childhood experience, having 4 or more, can really increase a lot of like physical health and mental health, the frequency that you will struggle with some of that. And so having those adverse childhood experiences is definitely a risk factor for suicide attempt or suicidal ideation. And then looking at some of the community-driven factors, lack of access to care. We saw some of that when we looked at the Missouri and Kansas comparisons. I know we have people from other areas as well. And then also looking at not just access to mental health care, but access to physical health care. Going to the doctor is not as simple as going to the doctor all the time for people, especially from a financial perspective. And so when we're talking about chronic pain and dealing with these more chronic illnesses, that can be a really big, plus a lack of access to care, that can be a really big risk factor. Suicide clusters are on here, and Laurel gave us some great information about those. Discrimination and prejudice, which I know that we're seeing a lot of that portrayed in our media right now, a lot of community divisions, of people divisions. And so that is definitely puts communities at risk for suicidal behavior, for other mental health struggles, et cetera. And then community violence. So when we're looking at, increases in theft and crime and mass shootings and those types of situations, we're seeing also the suicide risk increase. And then the cultural and environmental factors are the mental health stigma, which we've talked about, easy access to lethal means, and then unsafe media portrayals of suicides. And I'm just going to make some comments on the lethal means thing. It's a little bit more about proactive measures. So Laurel, I know that you're going to talk about that in a little bit, but I don't think I saw this under your information. Yeah. But we know that 25% of attempts happen within 5 minutes of the person deciding that they are going to attempt suicide. And we also know that 90% of people who survive their first attempt are not going to die by suicide in their lifetime. That the access to firearms really, or any lethal means, really, really, really impacts that person's ability to be part of that 90%, because that is so final, because that is so lethal. And so I think that you know, there is this whole side of legislation of safer gun laws and things like that, but there's also just practices that we can do in our homes to make accessing a firearm take a little bit longer. Having safe storage, relocating it. I know that you could, like, police stations will let you store firearms in lockers there. I know a lot of people can have gun storage and things like that. Maybe not knowing the code to your gun storage if you're someone who's at a potential risk, and having to get that from a loved one if you want to access a firearm for sporting reasons or whatever other reasons you might want access to that. These are all things that we can do to kind of reduce what happens in that 5 minutes, that impulsivity, making it just a little bit harder for that person to access that. And I think that it's just so interesting to hear, that 90% of people who attempt suicide and survive don't end up dying by suicide. And that, when we can reduce the lethal means, specifically firearms, which accounted for 55% this year, or last year, or 2 years ago, 2022, it's 2024, of suicide. So it's really interesting to kind of think about that. And then we're going to pop into warning signs. So those are our risk factors. So I would imagine that a lot of people in this training probably have risk factors. And I'm going to pause just a second because someone just put this idea in the chat, and I think it's brilliant. But the idea of putting breathalyzers on firearm boxes, so that somebody could only access that if they were not under the influence, that could be a way to reduce that impulsivity and ensure safe firearm usage. But back to what I was saying with risk factors and warning signs, a lot of us probably possess those risk factors. I could identify a good amount on that list that I have personally experienced, or that people I know have experienced. And that does not mean that we are all going to be suicidal at some point, but it does put us again at that increased risk. And that increased risk factor coupled with warning signs is when we really have to take a closer look at what's going on. So some warning signs of possible suicidal behavior include talking about being a burden or feeling trapped, or posting about it. Talking about social media, posting about it is part of that. And I think that that's where we see it happen. And it's not really always addressed. Finding ways to access lethal means. We just had that conversation. So if someone is searching for a way to acquire a firearm or something sharp or a medication that they wouldn't normally have access to, that's a red flag. That's definitely a warning sign to be taken seriously. I have finding access to lethal means on here twice, but increased anxiety is one. So watching someone's anxiety increase or them feeling out of control is definitely a warning sign. Extreme mood swings or like angry outbursts is a warning sign, especially if they're verbalizing like not wanting to be here anymore, or life is too difficult, or kind of some of those like more common phrases that you hear. Expressing hopelessness, feeling like there's nothing they can do to change their circumstance. Talking about wanting to die. I think that this one we sometimes assume is in an, I don't know if negative is the right word, but kind of in a negative way or in like a threatening way, or I'm frustrated and I want to die. But this can also happen in a very kind of like nonchalant way. People who have kind of like settled into this idea or struggling with this can talk about wanting to die in a way that maybe wouldn't necessarily raise red flags. In the way that if you were like angry or upset, it would. So that's something to keep in mind. Increased substance use, increased sleeping or decreased sleeping, some of those more general signs of mental health struggles. And then obviously making plans for suicide or giving things away, or making plans for end of life in a I don't know the right word, in a non-constructive way. So it might be beneficial for us all to have end of life plans for loved ones for reasons of like not wanting to burden them. But when that kind of takes a different turn, or when that comes, in association with some other warning signs or risk factors, it's definitely something that we should take a deeper look at.
So let's talk a little bit about protective factors. I mean, so essentially you'll see that these are the mirror of those risk factors we already talked about. So we want folks to feel connected to school, community, and other social institutions. And we also want that availability of consistent and high quality physical and behavioral health care. I thought this section was interesting to think about how we talked earlier in the presentation about folks who live in rural communities are already at a higher risk. And I'm sure that that is somewhat correlated to the fact fact that this availability of consistent and high quality physical and behavioral health care is an important protective factor. Because I think we all know, and especially if you're in the behavioral health care field, you have already experienced that there is limited resources for folks in our rural communities to access quality physical and behavioral health care. At Camber, we have families that sometimes drive 6 hours one way to access our inpatient and residential services. Then it becomes increasingly difficult to access and find outpatient services for those families at times too. So it's just, again, kind of one of those really somewhat actionable items that we can really think about how we can have a positive impact on ensuring that we can add this protective factor to folks in our rural communities as well. We also want to make sure people have those effective coping skills and problem solving skills. A strong sense of cultural identity can be a protective factor. Those healthy relationships, so supports from partners, friends, family, feeling connected to others. I think this connects to that social media balance we were talking about, right? So social media can provide some of these protective factors to people, as well as those risk factors. So there's a balance in finding how that is healthy for every individual and looks different. And we also want to reduce access to those lethal means that Alex was mentioning. And if folks have cultural, religious, or moral objections to suicide, that's also a protective factor for them. So we want to break down a little bit closer what some of those things can look like in real life for youth and adults. So for youth, they're at a stage of development where they're trying to understand who they are as an individual. So we really want to encourage youth to explore and learn about the world around them as developmentally appropriate. And the reality is that youth are going to have exposure to the world, whether you keep them in a bubble or not. If they're in school, if they're on social media, they're having exposure to these things. And so what's going to be most supportive, safe, and beneficial for those youth is if they have an adult or a parent, someone in their life that is helping them understand what they're experiencing at a developmentally appropriate level. We also want to encourage youth to identify their values and connect to activities that support those values, and that can feel deeply meaningful for youth and have them feel that connection to the community as well. Youth need to be encouraged to seek healthy relationships, and adults may need to help scaffold what a healthy relationship is. And we want to help youth find a balance, as we mentioned, between that social media and that in-person social interactions. Overall, youth should typically find it easier to access school and social institutions as well as healthcare. There's just more supports in place for youth to access these systems. Overall, youth are able to access Medicaid and other kind of safety net insurance programs and things like that than our adults, and also have caregivers who are making sure that they have those access and supports as well. For our adults, typically they've already developed that sense of self and identity. However, it may not always be a healthy sense of self. So they may need support in identifying effective and positive coping skills. Some of those maladaptive coping skills we think about is some of that substance use and misuse that Alex was mentioning. So we want folks to switch from that maladaptive coping skill to a more effective and positive coping skill that's a better impact on their physical health as well. It's much harder to develop a new habit as an adult, but it is possible, right? So we do want to make sure that we're meeting those adults where they're at and still providing them those opportunities to change those habits. Even if they've been doing the same thing for 20 years, they still do have the ability to change those neural pathways. It just might be a little bit harder to do it. Adults may need more support in keeping relationships and connectedness as they have fewer of those natural systems such as school. They may be working, but as Alex mentioned, they may work from home or be just more isolated in that work. So it may also be important to help adults identify their values and connect to ways to support those values just with our youth. And we want to help adults access that physical health care. It's really important. We all know that aging can greatly impact the body, which also impacts our mental and emotional well-being. So there are multiple physical health issues such as thyroid disease, other autoimmune diseases, among others, that can chemically impact our mental health. They have chemical changes that are occurring because of that disease that can impact our hormones in our brains as well. And so we want to ensure that adults are accessing regular physicals and healthcare so that we can add that protective factor to their toolbox as well.
So let's talk about what we're going to do when we suspect someone is struggling. And I put this infographic up here because I think it was a good kind of summary of some of the steps, but as mental health professionals, there are some additional steps that we can take within this. But the first thing is to ask directly about suicide. We know that asking about suicide does not increase the risk of suicide. We want to ask that question if we suspect it. We want to do it in a way that is not fearful or accusatory. You want to do it in a way that is led with empathy and that is led with understanding and support. And we really want to listen non-judgmentally and to really validate those emotions. We also want to keep them safe. We want to reduce their access to lethal means. We want to encourage that person or that family to remove, any sort of firearm or sharp object or medication that could be used pretty immediately. If that child is someone sitting in one of our offices, we want to be mindful of what they may have access to and what they don't while we're kind of working some of the next steps of how to care for them. This can always be a good time to start a safety plan. Honestly, throughout the process, there's going to probably be multiple safety plans developed. But I think that sometimes it can be anxiety inducing for someone to immediately kind of share that information. And so I think a great way to start that conversation is, what can we do to keep you safe? To validate what they're experiencing and start, hey, what are some of the things that you can contract to with me while we navigate what our next steps are? There's a lot of research around safety planning being huge in suicide prevention, and there are a lot of wonderful apps out there that can help you safety plan kind of in the moment. So it doesn't really take, you're not like, having to like Google, how do I safety plan? There are lots of apps you can have readily downloaded on devices so that if a child does say something to you or an adult says something to you, you're able to immediately respond, give them a resource, and make them feel seen, and kind of hold that hope for them in the time that they're feeling a little bit hopeless. And then just be there in that moment, be there as they take whatever next steps in treatment are necessary for their level of severity. Check in on them, make sure that they know that your support is not conditional or only one time. We want to help them connect. So we want to, and actually now that I'm looking at this infographic, that number is a little old. That number still exists, I think, but it's not currently the suicide prevention number. Talk about that in a minute. But yeah, help them connect, whether that's via a hotline, whether that's driving them to an emergency department if we are at that place, whether that's contacting a loved one or someone who is maybe already identified on a safety plan for them of kind of what they do if this is a struggle that they have. We want to connect them. We want to make sure that they leave our care connected to next steps, connected to resources, and connected to help. And then we want to stay connected and monitor warning signs maybe after crisis. So there's a lot of information out there about if someone requires inpatient hospitalization, things that you should do after discharge to monitor for and, reduce the need of readmission. So if we're talking about a really, really intense person who is really about to attempt suicide and has a plan and means to carry out that plan, we want to make sure that as we continue to work with them in the subsequent weeks and months, we're checking for those warning signs. We're having open conversations about it. And then we're promoting all of those protective factors, all the things that Laurel just went through with us. We want to make sure that we're helping the family, we're helping the individual, we're helping whoever supports that individual or whoever is a part of that individual's community bolster those and improve those and really make sure that that person feels that kind of wraparound support. At no point do we want to blame somebody. At no point do we want to sorry, I got distracted with the chat. At no point do we want to blame somebody. At no point do we want to kind of like put it back on them or minimize what they're feeling or invalidate kind of the extremeness of what that feels like. We want to make sure that we let them lead the conversation and we meet them where they're at. And also, as to the question in the chat about some of those specific apps, I do have a list of those apps and I will include that on my additional resources sheet that I'm now creating. It's going to be quite the resource sheet. We did some technological advancement training a few years ago. And so we were looking at all the different apps that you can use for safety planning and things like that.
All right. There were just a couple other things I wanted to highlight in the chat before we move on to this next slide, Alex. So someone was just mentioning that if folks want to kind of increase their mental health awareness and understanding, taking a mental health first aid training is really beneficial. And I definitely agree, accessing any kind of mental health first aid training is really valuable. I think most of our like teachers and folks that interact with our youth are typically trained in that too. And if they aren't, they should be. I mean, anyone really can benefit from those types of trainings. And then someone else was mentioning, as we were talking about access to care, that they worked at a community behavioral health care center, or a CCBHC. And there was not enough access due to sometimes lack of insurance or medical coverage. And so when they don't have coverage, it just makes it harder to find care. And then the wait times can be really long. And that's part of what we kind of touched on when we were talking about how youth are a little protected from that, because they do just have expanded safety nets for that healthcare and coverage and insurance, that our adults just don't always have that, unfortunately. Yeah. So painful. Yeah. Okay. So let's talk a little bit about assessments. So we spent a lot of time talking about facts and risk factors and protective factors. And we want to kind of give you something to feel like you can walk away with something that's something you can use, right? And so it can feel really overwhelming to think about how incredibly far reaching suicide is in our community. But the Columbia, I'm trying to find it here. Columbia Suicide Severity Rating Scale. I call it the CSSRS so much, it's hard to remember what the actual lingo is something that anyone can use to support someone who's experiencing a mental health crisis. So the Columbia Lighthouse Project is a resource for anyone, and it was created under Columbia University to disseminate the Columbia Suicide Severity Rating Scale, or the CSSRS. And it aims to save lives worldwide by making this protocol use universal. So you can visit that Columbia Lighthouse Project website, and you can access how to use the CSSRS in different settings. And that includes options for family, friends, neighbors. I think there's some specific information for veterans, all different types of kind of those subsections of our community that we've discussed today. And you can kind of see here on the slide just what some of those questions look like. They're very kind of specific. They're asking about specific things that someone's thought of or experienced. And then by completing this, you'll get that level of risk score of either low, moderate, or high. On this little snippet, we don't have all the information you would need to kind of take next steps, but by accessing the website, there's guidance on kind of next steps based on someone's rating. Obviously, if their level is high, you want to, reach out for that crisis support right away. I see in the chat that there's also an app for the CSSRS tool. So if we could add that, maybe, I don't know if you have that information, Alex, but adding that to that resource guide, I think that would be really helpful. I didn't know there was an app, so I appreciate someone sharing that. That's great.
Yeah, we got to tell all of our clinicians.
I know, right?
Yeah, and there is, and so the second, we're coming to the end of this training, but in our part 2, we're going to start with assessments and get a little bit more in depth. This was the most general assessment, the assessment that can kind of be done by anyone, that doesn't require a certification or training to do. We are going to get into some more intense assessments at the beginning of our next training. And one of them is called, which I still think can be done by most anyone, but it's called the safety. And there's actually a version of the CSSRS that includes that. So there's some different ways that this can be conceptualized with some assessments. So if you're going to be with us next week, you'll hear some additional details on that.
Alex, okay. Before you move on, I like that someone mentioned that they get asked the CSSRS questions at their doctor's office. I know that can feel kind of strange, right? But if you think about how physical health and mental health intersect, and how that is again, just another protective factor, another layer of assessing that in the moment, and more regularly decreasing that stigma, all of that, it's really good to hear that you're experiencing that at your doctor's. I think that's awesome. Although it can feel kind of weird, but I think it makes a lot of sense.
I have to fill out, it's not a CSSRS, but it's like a mental health questionnaire when I go to the doctor, and I get so excited every time because I'm just like, I love that you're asking everybody this. So I fill it out with pride because I love that protective layer. Okay, I'm going to launch our last polling question. Maybe if my little boy, there it is, we'll come back up. I think everyone's going to know the answer. I hope everyone's going to know the answer. If not, you will after our next slide. So what is the suicide crisis hotline number? Oh my God, it's not on there.
No, I can see where you meant it to be though.
Yeah. Well, none of these are correct, so I'm going to end this poll. The answer is 988. I don't know how
Yeah,
I ended up
everyone's putting
typing
in the
that
chat, so they got
incorrectly.
us.
Yes, love that. I was afraid for a sec. I was afraid for a sec too. I love everybody knowing that though. So yes, 988. That is our suicide crisis lifeline. It has been amazing. The research that had said, yeah, it was just a test for you guys. I needed
Yeah,
you guys to all tell me on the
100%
phone.
trick question.
It for all the research that's come out that about the expanded access since 988 is amazing. But I've also gone ahead and listed some additional resources. So the Trevor Project has a crisis hotline. SAMHSA has a treatment referral hotline for substance abuse. There's a veteran crisis line that you can send a text to. And then you can also do some talk to text crisis. So these are things, you know, if you have kids, if you are working with families, put these numbers in people's phones. I think that that is like one of my biggest suggestions is you might think you're never going to know it. Put it in someone's phone. That way it's there. They don't have to look for it. They don't have to think about it. You can just title it as crisis, like use in a crisis, and that will help hopefully motivate them to use that because they don't have to look for it. They don't have to do the Google search. They don't have to kind of feel that shame. They just can, it's right there. It's already in their phone. It's already entered. They can use it. So when you guys get the slides, you'll have access to all of these different help lines. And the last thing that I wanted to talk about today, I see lots of people saying thank you to the presentation, but we are opening Children's Mercy Camber Mental Health here in December. And so this is located in Olathe. It's an inpatient hospital for youth and adults. Our youth will serving are ages 6 to 18. There's a list of the services that you can that will be offered there. And we will, like I said, start taking admissions at the very beginning of December. I'm going to go ahead and put our admissions line in the chat, and just in case anybody wants access to that admissions phone number or needs any of this. But this is hopefully going to increase access to care in the Kansas City community. We're really excited about it. None of our other service lines are shutting down or closing, so those services will still also be available. And we are really going to hit it hard with making sure that our services are available to adults as well. So again, your your survey should either pop up in a browser, be accessible in the lobby till 2 p.m. A link will be in the thank you email sent. And then I think that Brittany's about to drop it in the chat for me. So there will be lots of ways for you to take that survey and get your CEU. If you are struggling still by like tomorrow at noon and you don't have that CEU, please send me an email, reach out to me, and I'll make sure to get it for you. But thank you guys so much for attending and hanging in there with us. It's always
Thank you, everyone.
everyone. Have a great rest of your day.
Bye-bye.